Okay.
Hi, Linda.
Hi, Linda. So, I have 5 o'clock. So I'd like to welcome everyone to the KVH County Public Hospital District number 1 Board of Commissioners regular meeting. Hopefully the technology will keep up and we'll be able to share our information and not talk over each other, but just have a really informative meeting. Mandy, could you do our roll call?
Yes. Bob Davis.
Here.
Matt Altman.
Here.
Erica Libanow. Here. Sean Moore.
Here.
Terry Clark.
I think it said Terry Clark here.
Peterson.
Here.
Ben Martin.
Here.
Mandy Olson.
Here.
Terry Barr.
Here.
Rhonda Holden.
Here.
Morgan Anderson. Here. Linda Navarre. Here. Amanda Scott. Here. Jeff Yamada. Michelle Worrell. Here. Ron Erlacher. Scott Olander.
Here.
Vicki Matero.
Here.
And then if there's any other staff on the line, if you can please let us know who's on. Lisa Potter.
Great, thank you. So our first item on the agenda is the approval of the agenda. And if there's any items to be pulled from the consent agenda. Do we have a motion to approve the agenda?
Yeah, this is Matt. Sorry, I'll second after Erica. This is Matt.
So, Erica, motion, Matt seconded, all in favor?
Aye.
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 Any opposed? Consent agenda. So do we have a motion to accept the consent agenda?
This is John. Motion to approve consent.
Terry, seconds it.
And Terry seconds. All in favor?
Aye.
Aye. No opposed? And we're privileged to have Linda Navarre do a presentation on our annual report. Linda, are you there?
Yes, so you want me to go ahead and get started now?
Yes, please.
Okay. Well, first of all, my request is to ask for approval from the board of the update to the code of conduct. The compliance committee reviewed the code of conduct in 2019, and with staff feedback and also with leadership feedback, we made some recommendations to improve this document so it's more information can be considered clear and understandable. So it's a way of staff being able to refer to this to really understand clearly what's expected of them. So our first request is to answer one, to request your approval of the updates and answer any questions that you may have regarding the code of conduct document.
Okay, so we need a motion to accept the approval of the update.
Yes.
So do we have a motion?
This is Terry. I so moved to accept the code of conduct.
Yeah, this is Matt.
So Terry made a motion, seconded by Matt. Matt. All in favor, say aye.
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 No opposed?
Aye.
Okay.
So the second is, I let Larry, I am echoing. Sorry. So the compliance program annual report, and which is a summary or an update with the compliance program in 2019. And I do recognize in the document on the first page, states the compliance program structure or performance of the elements. We should say 2019, not 2018. In the outcome of our work plan for 2019, if you refer to the 2019 work plan document, you can see, yes.
Linda, I don't know if it's anybody else, but I'm hearing an echo.
Yes, I hear it echo as well. I'm just on my cell phone, so I'm not quite sure what to do to stop the echoing.
Whatever you just did stopped it.
There's no microphones on at the.
Yeah, Linda, it's stopped now, so
Yeah, now it's not echoing.
talk quickly.
No.
Okay. So I'm not quite sure. Did you hear me regarding the compliance report, annual report regarding on the first page, there was an error with the date. It should state the compliance program structure. Our performance of the elements should be stated as 2019, not 2018. And in summary, there's 7 elements to effective compliance program, and there were specific actions that were taken to support activities that would monitor risks that we identified and actions taken to mitigate them. We have throughout the monthly meetings that we have with the compliance program, we've had more data being reported out, which has been helpful since 340 team, the privacy officer as well as security officer, recognizing the increase in ongoing threats, especially with privacy and cybersecurity concerns, and also recognizing the 340B program, which is an excellent program of providing funding for additional services, but does require a lot of auditing. So there's been ongoing auditing and reporting out of that to ensure that we have some good oversight of that program. We did in 2019 have a work plan, which is the second document. So the 2019 compliance work plan. There was reporting out of how well we accomplished our goals with that, and policy and procedures. So on the top, we were effective in meeting our targets for that, as well as updating and reviewing the compliance program, and also ensuring that we had reporting out last year to the board. The one thing that we did struggle with was ensuring that all staff review the code of conduct, which is part of our education plan. That was an assignment through Biz Library, and through the years we sometimes have met target and other times not, and this is one of the areas that we're going to be working on to identify what that barrier was to getting 100% compliance with that. We did have some changes though to with the ACO that we're involved with that did require providers and administrators to ensure that they've reviewed fraud, waste, and abuse policy and attestations to ensure that we abide by the regulations, and we did meet 100% compliance with that, so that was very favorable. And so we've had continuous opportunities to provide guidance to staff if they have concerns about compliance. We've had very few calls to the compliance hotline. A lot of times it's more or less just phone calls with inquiries wondering if there's any concern with anything that's going on related to whether it's documentation or staying with making sure that we're following state guidelines as far as privacy. So there's only 4 investigations, formal investigations that occurred, and there was no indications of any concern of reaching any regulations with those. A lot of good educational opportunities usually come from that, where there's helping staff better understand what those regulations are and how they can also be a part of educating others about that. We've had good attendance.
Linda,
Yeah.
sorry to interrupt. This is Matt Altman. So I see the confidential hotline. Is that a number directly to you?
It is. It only comes to my phone, and it also there's an indicator on my email that lets me know that has come through, and also it records it as well.
Okay, and you, it's confidential because when you get that stuff, you sort of put on your hat as the compliance officer, and is that the idea? Is that what maintains confidentiality?
It is. A lot of times, even what we state in the code of conduct is we try to maintain that confidentiality as much as possible. A lot of times, we're asking the reporting individual if they're comfortable with us sharing, who it is that has this concern. And for one of the instances that we had, it was related to actually engaging that staff member and helping us identify how we can kind of have a better process. So it feels better for the staff involved and how they're able to identify who's placing an order and who's approving orders. Others, we had an outcoming call from a community member, and it was related to the care of their family member. So it actually just really needed to be involved into our grievance process, and as well as helping staff members understand the roles within their place of work and what their documentation requirements are. So a lot of it is once they feel comfortable knowing that that we're glad that they contacted us and trying to engage them in either a resolution toward or helping them be a part of how to make it share the education. They've been really welcoming to reveal their name.
Okay, thank you.
Yes. So we're at with human resources, and there's been a lot of support by the privacy officer to help them work through any concerns of privacy violations that staff may be involved in and what the disciplinary process is. And so there's been really good engagement and ensuring that our policy and procedures are consistent along that when we're doing those investigations and any disciplinary action that's taken. The one auditing monitoring thing that's noted on number 6, the advancement in fishery notice. This is with CMS requirement that Medicare patients be informed if there is going to be, for example, a lab test or imaging test that may not be covered by Medicare, and helping them know potentially what the cost would be and helping them understand what the consequences would be if they didn't follow through that testing. It's one of those things that is really challenging to providers and staff, that there are some tools and servers to kind of help alert them when it may be needed. A lot of education to patients on what this means at the time, and we've definitely had some improvement. The one thing to note, though, is our billing staff are very cognizant of this, and they don't bill for these services that we don't have this AVN that's required. So we haven't had any concerns to date that I've been made aware of where we billed inappropriately. Instead, unfortunately, it's resulted in us not being able to charge for the service. So you can see on the outcome there that one of the areas we focused on was the scans, which are very expensive, and when we're looking at bone density. And we did make some significant improvement on a month-to-month kind of snapshot of having that AVN on file, and have not had the patient complaints regarding AVNs like we've had in the past as far as volume of those. So making some improvements, so we're just going to probably just keep an eye on that and see if we're continue to make some ongoing progress. Business associate agreements, we're continuing to work to have an efficiency with having a good process of finding all the older ones that are still in effect and having them logged. And we have already set up a good log system that meets the new requirements of having all the key criteria for that. The security risk assessment against cybersecurity is always an ongoing and continuing to be a serious threat. We did have our other annual assessment done in December, and any time now we should receive the final results on that. And Jeff's there, he can probably comment if he's received them since our last compliance meeting. But he's maintaining a work plan for that and prioritizing things that need to be done to ensure our security of our information. And one of the things that they did do right away is, you probably noticed that with it making us all change our passwords on a cadence to, again, better support security for that. So they've done some good changes, and also it's mapped with a lot of badge swiping, and that eventually will occur with login into computers, which will be helpful. Ongoing through part of the audits, and noted in the compliance report that we did have some findings. We caught 2 incidences with 2 different providers in which after they had left KVH, the third-party administrator that we contract with, our information that we shared with them about taking those providers off the list just didn't get processed through their system like it should have. And so we had some prescriptions that we had to notify the manufacturers of the medications that should not have come through 340B, and had a process for repayment to those, and we're ongoing work with the third-party administrators to ensure that doesn't occur again, and make ongoing contact with the manufacturers to make sure we're really transparent with what went on and what our improvement process is. And then the last is related to the privacy officer investigations, and we did have 4 reportable breaches that we were required to report to HHS on that. One of those was that Armada breach, and that was related to duplication of billing that occurred from our contracted service for billing that involved 8 patients. And you'll probably recall that we did notify the patients verbally as well as in writing. The patients were real appreciative of that, which was helpful just to kind of have a nice personal apology for the incident and what we were doing to correct that. The other was related to considered category of curiosity and appropriate access of a patient record, the results of disciplinary action, and then 2 others related to not following policy and attention to detail, and those were so a total of 4 that was reported. A lot of other investigations that just resulted in some ongoing education of staff to ensure they clearly understand how they have to be so careful to really think about how they're using the information that they have, and accessing appropriately and processing it to try to reduce opportunities for breaking down the security of the personal health information.
Hi, sorry to interrupt again. This is Matt Altman. One of the things I wanted to mention is I really appreciate you and the rest of the administration keeping us informed about this stuff as it happens. It's nice to read about this in your report and remember back to when we heard about this the first time. So we're not getting a lot of surprises in the report. So we really appreciate that. So thank you.
Oh, that's good. Oh, you're welcome. Do you have any questions regarding any of the content in the annual report or work plan?
No, like Matt, this is Bob. I just appreciate how comprehensive it is. And that going over this information does bring back memories of things that we've covered for in the past and just continual improvement. So I think it's great. On that pharmaceutical issue, we were trying to negotiate with the pharmaceutical company to get that reduced. Have we made any progress on that, or is that more thought area?
So the first one that we identified with the first provider, there was an agreement for us to repay exactly what was the cost of the medication at that time. I know the second provider, we're still working with the manufacturers on that. In fact, we even have a call next week on that. So NASSR's been very good about ensuring he's giving really clear information about what the incidences were as far as the medications that were processed, and as well as what the cost was at the time. And the manufacturers are going back and checking in their records to see if that aligns. And then as far as their agreement to go forward with our repayment of that. So that's my understanding that was reported out to me anyway.
Okay.
And how it's working.
Any other questions from the board or anyone else for Linda and her compliance report?
John, John is the representative from the board on the compliance committee. John, do you have anything to add to that, or did she cover everything?
John, no, I thought it was very thorough, and it definitely reflects stuff we've covered in the compliance committee meeting. So I think it summarizes very well. And, as you noted earlier, Matt, we should all feel good as to how thorough it is.
Great. Thank you, Linda.
All right. Well, thank you for the opportunity to share the information. Have a good night.
Yeah, really appreciate it.
This is Terry. Can I ask a quick question?
Sure.
So if I wanted to watch the live stream, how do I find it? I tried searching on YouTube and can't find it.
Okay, that would be like a Mandy Reed question.
Lisa,
If you
Amanda?
just type in Kittitas Valley Healthcare, it's one of the top videos on the list. It says live now.
So I search YouTube and then just type in Kittitas Valley Healthcare.
Yep, and you'll see a list of videos, and then you'll see the one that says live now.
Oh, I see it live now. All right. Thank you very much.
So, just a reminder, we'll have public comment at 5:30 like we traditionally have. Does that give you enough time, Mandy Olson, to go over quality, or?
Depends on how much we're going to talk about infection control as part of quality.
Oh,
So
Okay.
can I propose, Bob, that we have a couple of very specific items we'd like to cover, one of which will be the finance report, and then also Dr. Martin's proposal for a resolution regarding emergency credentialing. But as I look through the list of other things, almost all of which is COVID-19 related, I don't think we're going to be able to chop it up quite the way we we usually do. So I would ask that we do those reports that need to be done, like Dr. Martin's and Scott Olander's, and then just kind of slide into our report about what we're doing here to be ready for COVID-19, if that's okay.
So I do think
Okay.
I could get through then the dashboard and the normal quality things in like a few minutes. So.
Does that make sense?
Okay. Yeah. So let's have Dr. Martin, if you can do your request.
Very good.
Go on to public comment.
Okay. As you know, we've been engaged in extensive planning around how to manage an anticipated surge related to SARS-CoV-2 and the resultant COVID. We have existing policy that allows for providers to essentially extend their privileges as needed to keep patients from harm. In order to activate that, the board would have to acknowledge that we are in a state of emergency, and you have a resolution before you to accomplish that. And that's resolution 2020-01.
So you need a request?
Yes, I'm asking you to, I'm asking for a resolution to acknowledge that we are in a state of emergency and that we may be asking providers to work outside of their normal training and their normal scope of practice. And in the words of Cardinal Richelieu, to do what needs to be done in the name of France.
So we have resolution number 20-01, authorizing emergency privileges per policy. Do we have a motion to accept that resolution?
I'll make that motion, Mr. Matt.
I think I'd like to ask a question before we move forward. This is John.
Sure.
So
Yeah, go ahead.
Was this resolution just recently drafted, or is this boilerplate from some previous negotiated document?
The resolution was drafted this week. The policy was drafted in 2002. So
Okay, so my question is, the phrase that says that the board hereby authorizes the following physician's authority to grant emergency privileges. My preference would be that reads, because right now it's very unclear, can any one of those individuals do it, or does it take all three to do it? So I personally would prefer some clarity. Is it like 2 out of the 3 following officers, have this authority? So I don't know if the fellow board members have any questions about that language, but I would personally like to see some clarity on that. And then secondly, if somebody can fix the typo in my name, I'd appreciate that also. So.
Oh yeah, there's an H there.
Sorry, not trying to be a troublemaker, just, so do the board members have any thoughts on that clause?
Well, so what is the rule there? Is it all 3 of you, or is it 1 of you, or how does that work?
my preference would be for it to be any one of the 3, and the reason for that is in anticipation of the possible contingency that 2 of the 3 may be incapacitated at any given time.
And when we created that list, that was the thinking. So as we identify a provider, and my concern is that someone who currently has ambulatory status may be pressed into service as on the inpatient side, and we want to be able to go ahead and execute on that regardless of whether we can immediately put hands on Dr. Martin or Dr. O'Brien or myself. So any one of those would be able to execute on that.
So John, what if it just read that the board hereby authorizes each of the following physicians' authority to grant emergency privileges? Would that do it, to say each of the following physicians?
Yes, that would at least clear up the vagueness of how it currently reads. My gut instinct, though, would still be to have a phrase, unless they're incapacitated, I would appreciate 2 of the 3. And again, it's just one of those things where nobody can go rogue unless we're in really desperate straits. And again, it's hyper paranoia. Obviously, I think all 3 of those individuals are capable and suitable to make this decision. I'm just putting it before the board do we want any second level checks as long as they're not incapacitated? I just put that out there for discussion.
Well, let me ask, yeah, go ahead, yeah.
So this is Terry. I was thinking that kind of falls into the quorum thing. We have 3 people, and 2 of them would make a quorum. And so I would think that we could have the 2 of them do it, and that way we'd have a quorum. Would that cause too much hassle for you to do that if 2 of you guys said yes?
I would suggest that we are about to start operating under conditions called crisis standards of care. And the definition of that is when staff, space, or supplies are inadequate to meet the demand as a result of a disaster or a pandemic. Given that those are the conditions that we're expecting to operate under, I think that this kind of privileging is more appropriately an executive function than a committee function.
The one concern I have is how we would define incapacitated. I'd be worried about sort of trying to nail that down, since each of these people, the chief of staff, chief medical officer, chief executive officer, it seems like, the buck stops with one of them on this. So I don't know. I don't have a problem with because this is an emergency situation, and after this, after this crisis is over, then we'll go back to the regular situation. But I don't know. I don't have a problem with each of the following positions, and that's mostly because I don't know how we would nail that down to say when one would be sufficient. I'm not sure.
That very fair point. I would just say, does Bob or Erica have any thoughts on this matter?
Erica here.
Go ahead, Erica.
Thanks, Bob. In the respect that time may be of the essence and hypercritical as well, I am in favor of any of the 3 rather than requiring a form.
Okay. And then my only comment is, at what point are you no longer under emergency privileges? Like, is that from state or from federal or from county? Like, who dictates when you're no longer under that
I would look, this
umbrella?
is Julie, and I would look to the county and the public health
Okay.
department to help us know that it was time to stand down in terms of, basically this is part of our surge planning. So I would say
Okay.
county. Dr. Martin, do you disagree or?
I think when the county stands down from a state of emergency would be appropriate.
Is there any reason to put something like that in there so that so that this isn't Caesar taking over the Senate or something? And 2 years down the line, the board is out on the street, not doing anything.
I would suggest that a resolution withdrawing this act is the appropriate way to do that. And we may have other emergency resolutions that we're bringing forward, so I would look to unwind all of those with a resolution saying anything done under the umbrella of emergency is now being withdrawn. That's, looking forward, that's kind of how we had planned it.
So this is Terry.
To answer your problem?
Yeah.
Okay, this is Terry. I had a question. So we have 3 people that could do the emergency credentialing. Is there a hierarchy on those 3 people so that they all 3 are operating independently?
I would suggest there's an advantage to having us operate independently if need be. It may be that we are in 3 separate parts of the hospital and somebody needs to proceed with something that we need to bless. I also think it's unlikely that Dr. O'Brien would be in that role precisely for the same reason that he's not here tonight. If we get to the point where he's on the front line, we are thin because he is at risk.
Okay, well, I think this is Terry again. I think this is good that we should do that. just for a 60-day period of time, is that correct?
No, it would be for the duration of the emergency.
So again, there is existing policy that's 18 years old, and this is just the board acknowledging that the exercise of the existing policy is appropriate at this time.
So if the credentialing only lasts till the end of the emergency, what time frame do we have to re-credential them after the emergency has been called off?
So this request, this resolution is different than the temporary privileges that we granted to our new providers for initial privileging and re-credentialing. This would actually take the existing physicians who are credentialed to practice here and allow us to change their roles. So again, the providers who work in our clinics, by and large, only have ambulatory privileges. What I see this doing in most cases is allowing us to, without further action, grant them active privileges so that they can work in the hospital. So this is different than the initial and re-credentialing that MEC typically brings before the board. Those will be done and have been done for this month under the temporary privileges that Dr. O'Brien and I already have signed and authorized. So those are two separate actions.
I understand the difference between the two different credentialings now. Thank you for the clarification.
You bet. Sorry if that is confusing.
So John, what we have now is the board hereby authorizes each of the following positions authority, and then the misspelling on John's name, but those are the two changes. But yeah, Bob, I think you were going to ask how John feels about those responses, so I'll just let John respond.
Yeah, so I appreciate those two changes, and I'm good to move forward with those.
Okay. So we need a motion for the resolution 20-01 with the changes mentioned.
I'll make the motion as amended. Yeah.
Second, Erica.
Okay, Matt made the motion, seconded by Erica. All in favor? Say aye.
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 No opposed?
Thank you.
Thank you.
Thank
Dr.
you.
Martin. So at this time,
Thank you.
we will move
Can I-
into,
Erica here.
yeah.
I take a moment to thank all the providers who will likely soon be stepping up from their current roles into a new role that is only going to be somewhat daunting, but very much needed for them to step up. And I'm very grateful that we have them in our community and that they're willing to do so. So thank you to all of the providers.
Thank you.
So you're saying that under public comment?
This is Terry. I want to go on record as saying I don't so want to thank any of the providers.
Oh, thank you. Thank you very much for putting words into my mouth.
No way, this is Terry.
At this time, we will open for public comment and announcements. If there are any announcements or public comment, if we can keep it to 3 minutes, that would be appreciated. Are there any public comments?
This is Mandy. I just wanted to let you know I have not received any emails.
Okay, thanks, Mandy. Yeah, I mean, I think it goes without saying as a public comment how, for a community, how grateful we are, not just for the hospital staff, just sticking with this, doing their job, when they putting themselves at risk, the providers putting themselves at risk, senior leadership has just done a really impressive job. And then, obviously, I think we all agree that Mark Larson has really led the state in calling this out, bringing it to our attention, and Tristan Lamb over at the health department as far as the public health director and their information person, Casey Knudsen. So shout out to senior leadership, hospital staff, and the public health officers of Kittitas County. I think things could be a lot different. We could be in a lot worse crisis if we wouldn't have jumped on this as early as we did. So, thank you. Any other comments? So then we'll just move all the way through, start with Mandy, quality.
So, what I think you received an email from Mandy with a quality improvement dashboard. This is a new dashboard for 2020. What I would like to say about this dashboard is there's a lot of great data on it and a lot of things to be proud of. Unfortunately, we cannot give much detail on improvement work we've taken on individual measures because we've been focused on preparing for and responding to COVID-19. So there is, I could point out a few great data points, but in honesty, the staff are not focused on these improvement activities right now. So our median time to stroke was great. No falls, no needle sticks, no hospital-acquired infections. We've got our workplace violence data on here now. We had no adverse medication events. We've got good employee reporting of incidents, using their safe boards and staying on target, and we had only 2 incidents that required additional monitoring for our patients. So there is a new glossary to go along with this new dashboard, and I'm happy to answer questions about the new dashboard, but I really don't have very much to add beyond that.
Mandy, this is Matt Altman. I think it's going to be really interesting after we get through this pandemic, with all the cancellation of the currently unnecessary surgeries that we need to do. It's really going to change some of our numbers, because we might have several months where no one, where we didn't have to do any sepsis bundles, where it would just be zeros all the way through, few restraints and all stuff like that, with this focus on COVID-19. So it'll be interesting after we get through this to look back and see how it affects the data that we have and the numbers.
And I will say that is one thing we've been considering, right, during a crisis like this where you have increased volumes, staff doing different roles, new procedures. Incident reporting is really critical right now in identifying errors when they happen and having appropriate response to errors too. So seeing where we can simplify and error-proof these new processes and supporting our staff in that is really important right now.
Is there any thought to reporting specific data on the COVID-19 response and sort of we're getting some of that data from the daily reports and things, so that may be plenty. But I wonder if there are any COVID-19 specific numbers that you think we should be getting, monthly.
I can't think of anything beside raw admission numbers.
Yeah.
Length of stay may be useful.
That's true.
Number of ventilated patients.
Mm-hmm.
Right.
The other thing we might want to look at is how we're accessing those federal and state waivers, to your point about length of stay and excess of 25 beds, things like that.
Okay. Well, yeah, that's just a thought, anyway.
The other thought is that COVID, the disease may actually trigger some of our automated quality metrics around the sepsis bundle, whether
Yes.
that's appropriate or not.
Yeah.
And we may want to be able to tease that out in retrospect.
I do know that CDC, NHSN put out yesterday that they've created a new module within the CDC where we report surgical site infections, and they had a conference call scheduled to orient people to that they've now delayed. So I think they're understanding that we want to have data and understand epidemiologically what's going on with this and what's happening in our hospitals, but there's also a resource burden. So we don't have infectious disease people looking at numbers per se right now and doing chart audits. They're working with staff on PPE and isolation precautions. So.
Right, that's understandable. Thank you.
Mm-hmm.
Any questions for Mandy? Thank you, Mandy. Appreciate it.
Yeah.
Look forward to seeing more of that. So CEO's report from Julie.
Yeah, can I, is it okay if we have Scott Olander deliver the finance report first? Because mine just overlaps with operations and the COVID.
Okay. Scott?
Yes. You've got my report on pages, the written part is on pages 40 and 41 of the handout. I'd like to turn to just page 45, which is the P&L. And even though it's March 26th today, February feels like it was a long, long time ago. But we had a pretty good February with, we missed our revenue target by just $7,000. We were a little short with inpatient at $183,000 shortfall. We exceeded revenue budget with in outpatient, and then we were short with physicians. We had some key providers, our orthopedic provider and a GI provider out on vacation for part of the month. And so it was a shortfall with the clinic revenue. With other
Scott, do you think you could shape up and try to get closer than 7,000 next time? That's pretty good.
Thank you. Well, Jason Adler deserves credit for getting the budget as close as we did. But we will try, although it won't be in March or April. We had received some grant revenue, which helped us with the other operating revenue positive variance. $160,000 Ames grant. There's some more coming on that Ames grant, and about $181,000 of GCACH funds. And then with the expenses, we were, as noted, we exceeded the budget by almost $50,000. We had some startup expenses related to the ENT clinic, which the ENT clinic revenue and expense is not part of our 2020 budget, but this is a great service line for KVH, and so we will have some variances ongoing related to ENT. So we ended up with a positive operating gain of almost $67,000 with a net income of $227,000 for the month. And then if we turn to page 44, you can see we have some positive trends with related to financial sustainability. We benefited from the days in AR calculation. Our overall days went down just a little bit, but the way the calculation works, we came down 1 day from 85 to 84, and our payer mix is the percentage of commercial is climbing for us, and at 34.44, and so we felt like we made some pretty good progress in 2019, but we are making even better progress in 2020 with increasing the payer mix. And Jason did dig in to see where that which payers where we're growing, and it's we've had a good growth with Regents, and That is a contract that we just recently successfully renegotiated, so this will help us with some of our income, and this would be unbudgeted additional reimbursement that we hadn't anticipated. And then the only other thing on this page is just we did drop 11 days in our days cash on hand. We spent about $1.2 million of additional money on as we completed the Medical Arts Center building, and we spent about $460,000 for capital equipment for the ENT surgery equipment and ENT office equipment. But not a bad month for the month of February. Are there any questions related to the stats are there, and the stats are mixed, but any questions related to February?
Scott, this is Terry. I have a question regarding on that page 44 under the payer mix. I noticed that the self-pay has gone up about 0.5% for the year so far. Do we anticipate that to continue to grow from last year?
I wouldn't. The answer is I don't know, but we have what we did last year to get it to drop is we are working with in our emergency department to assist patients that come in without a pay source, without an insurance plan, and we're helping them enroll in either an exchange plan or Medicaid if they're eligible, and those efforts are ongoing. So I don't know that this is a trend quite yet. You know, it's up from where we were last year, but we have the same pieces or people in place that are helping our patients find coverage. So I don't know that it's a trend that I'm concerned about quite yet.
Okay, thank you very much, Scott.
I think John came up with this at our last finance meeting, was to restart the financial sustainability committee again, knowing it's gonna get chaotic. It's gonna be a tough go. So just wanting the other board members to know that sustainability committee is going to get going again.
Yes.
This month looks good, but next month is going to be hard.
I can talk a little bit about next month and some of the additional work that's going on, if you're ready.
Yeah, that'd be great.
But before I get to that, I just wanted to also just highlight after the financial statements, there is a Mitchell's grant report, and this is the work that he is doing, and the grants in the first column that has the kind of the brown or the orangish, those are the current things that he was working on this last month. He was focusing on those efforts, and then you have the other grants that have been approved. And but anyway, it kind of hopefully makes this report a little clearer about some of the efforts that we have ongoing to obtain funds via grants.
And he can work from home. He can still apply for these.
He is working he has been helping in at the visitor's desk. He's been helping in the pop-up clinic, answering phone calls, and he's also been doing some work from home with the grants too.
Great.
Okay, I'll talk a little bit about some efforts that we have going to excuse me, does someone have a comment?
No, go ahead.
Okay. Just to help us maintain liquidity, I have reached out to the two banks that we work closely with, Casimir Valley Bank and U.S. Bank, to see, inquiring about a possible credit line for the hospital. And they're both receptive to offering us a credit line, and so I may be bringing you a request to a resolution to approve a credit line next week. They're both, we've sent financial statements for 2018, 2019, and through February to both of the banks. They're evaluating our creditworthiness and may provide a credit line that we would bring to you for your consideration next month.
Do you have a certain number in mind?
I had initially asked for a $5 million line, and one of the banks had offered that they thought they might be willing to extend even more than that. So as high as perhaps $12 million if needed.
So this is Julie, and I'd just like to say that one of the conversations that Scott and I will be having is whether, depending on what the runway looks like to receive some of the funding that's supposed to be coming, whether we want to use some of our debt capacity, which would mean going to a line of credit, in order to preserve our cash. So our cash position is relatively strong, and I would rather err on the side of caution when it comes to anticipating federal funds. So that's something that obviously would go to the Finance Committee and a conversation that would come to the board.
Related to liquidity, I've just been evaluating, our current position, and KVH has about $30 billion of investments that we have, cash and investments, and 15 of that $30 million is in government bonds, and we've structured our bonds so that of that 15 million, about 8 million will mature in 2020, and so we have those funds, that 8 million, and then we also have another $9 million in the project fund related to the MAC that we borrowed money for that we have never drawn on. So that $9 million could be drawn down at any time we want it, and the $8.2 million we could access as needed. As we have investments that mature, we are investing short. We're giving up earnings for liquidity at this point. So I feel like we're in a pretty liquid position to deal with some of the winds and the storms that are out there. But as Julie said, if we can have a credit line, we would perhaps consider using that as an option to maintain cash too. Questions?
Any other comments from the board?
I would like to talk about what we're looking at for potentially March and April financial results.
Okay.
The month of March, for the first 2.5 to 3 weeks, have been trending pretty well. This last week and a half, we've seen significant drop off in. We stopped doing elective surgery on Monday the 23rd, and then so we've had a drop off in surgery revenue, and and the patient volume to the clinics has also significantly deteriorated. And so, from a revenue perspective, although March was looking to be a pretty good month, I'm looking at, I would project that we may have a revenue shortfall of $1.8 to $2.3 million below our budget target. And with we still have expenses. We have this pop-up clinic that we are supporting. That's costing us over $100,000 per month of expense with not much revenue related to it. And then as volumes both in the clinics and through the ER have gone down. We just don't have a lot of ancillary revenue. So for the month of March, we may be looking at posting a loss of about $800,000.
Wow.
And then, if the trends that we see the latter part of March continue into April, because we have, although we're expecting a surge of COVID-19 patients, we have not. There does not seem to be much in the way of patients in Kittitas County. We may be looking at a revenue shortfall for April of from $4 to $5 million under the existing trends, and so then the losses and the corresponding loss that we would post for April would be anywhere from $2 to $2.5 million.
And it's really
these assumptions.
help. We're going to get any federal or state help.
Yeah, and these assumptions do not. I don't assume that there's any federal or state help with those numbers. I was on the phone this afternoon about there's some potential FEMA money that is available, and it would help us with some of the incident command expenses that we've had the last month, and it would also help us with the pop-up clinic and the things directly related to the COVID work that we're doing in the clinic. It will not do anything to help us with the shortfall from elective surgeries, but there is some federal money coming in this package that the Senate approved that may help with some of that. So I'm giving you some very, very disappointing and ugly numbers, but those are kind of worst case numbers, and they don't assume any support. The FEMA money that is potentially available to help us with the pop-up clinic is 75% of what they determine to be allowable expenses related to that.
Any other questions from the board? Thank you, Scott. So, Julie, do you want to go start
Yes.
off, and then we'll just go the rest of the way through operations?
Yeah, and again, I apologize. I should have been paying more attention with the construction of the agenda. First, I wanted to call to the board's attention the fact that I think it was about 4 o'clock this afternoon, I sent you all an email that will be pertinent to executive session at the end of this meeting. So if you have not received that, please email Mandy Weed or let me know. And then I wanted to thank the board for allowing us to present this package largely as a verbal report. As you can imagine, things are moving pretty quickly. What I would like to do is kind of go through the incident command structure. Frankly, to back up a step, I can't think of anything that's not COVID-19 related to report to the board. So if something occurs to me, I'll let you know. But I would like to talk about the incident command and how that's being managed, and then regionally talk a little bit about the DMCC structure. From that, and everyone will have their own report, but I specifically want to make sure that as we move into operations, Morgan Anderson can speak to PPE, Carrie Barr, the COVID clinic and other clinic reorganization issues that are going on. Rhonda and Vicki have been up to their necks in surge planning, so to talk about that. Mandy Olson, infection control and safety. Dr. Martin, medical staff reorganization and planning. Michelle about communications, EOC, and unified command. And then Amanda Scott has been working to get as many people working from home as possible, and she can speak to our call outs and things like that. And then spoiler alert, Scott already told you that March and April are not going to be stellar financial months. So if folks, as you go through your operations report, can touch on those things, I know you'll have other things as well. Incident command here is the senior leadership group. We meet at least daily It is senior leadership plus Micah Bruner, who is assisting with security, our communications with the Emergency Operations Center, and environmental services. And then Jonathan Hibbs has recently joined Incident Command, and Morgan Anderson will be talking to you from a materials management perspective. If we didn't understand before how critical Morgan and her team are, we certainly do now. So every morning at 9 o'clock, or we move it around sometimes, we meet to get updates, and then if need be, we meet once again more briefly in the afternoon. So that's our daily incident command, and I truly believe it has really, really served us well. And I want to thank Michelle, because Michelle and Micah really are sort of leading the structure of that and making sure that we stay on target and do all the reporting that we need to. The other thing I want to talk about, and I welcome any input from people who listen to this, the state is set up into essentially 2 regions for an incident like this. And one region they're talking about really is the west side of the mountains, and everything east of the Cascades is another region. But within those regions, we have what are designated DMCCs, or Disaster Management Control Centers. The Disaster Management Control Center that we are assigned to, it includes Kittitas Valley Healthcare, Yakima, or VM Memorial Yakima, Toppenish, and Sunnyside. And the Disaster Management Control Center for those 4 facilities is VM Memorial. So this is a system called READY that very recently we've restructured emergency response in the state of Washington into this type of system. So that we are exercising and drilling this in real time. So just very recently, today I was talking with Dr. Larson. We are trying to get the 2 public health officers and the 4 CEOs of the hospitals on the phone together to see how we're going to execute on this plan in our sub-region. Adding to the complexity of that is, we all know that with the sudden closure of Astrea in Yakima, VM Memorial was already very much stretched in some areas. So that is, as we look forward to where our patients might be landing, whether they're Kittitas Valley healthcare patients, or if VM Memorial is perhaps pressed for CCU space, really looking for a way to keep an inventory of the assets, the equipment, the personnel, the beds that people have on hand, so that we can do as little transportation as possible, preserving our EMS services, but then also making sure that we're delivering care to the COVID-19 population. But keep in mind, at the same time, we are going to be having STEMIs and strokes and traumas and babies being born. So we want to make sure, as things get overwhelmed on the west side of the mountains, that when we have a STEMI, or we have a patient, we need to get relocated as quickly as possible, that we've preserved the capacity to do that. So that's sort of the regional picture. The state recently, in fact within the last week, has brought on some new personnel to manage this. And it may be that the state pulls the trigger on a strictly regional system. And in that case, the DMCC for the east side of the mountains would be in Spokane. So we're a little bit concerned about that, and that we don't think that Spokane is really that in touch with what our services are here and what the geography is and what our limitations and abilities might be. So we're hoping, I think at this point, to keep that control in Yakima. And anybody else have anything to add to that?
Just that as part of moving to crisis standards of care and the DMCC decision-making structure, that would also include decisions about resource allocations and I started having conversations today with Dr. Marty Brugman, who's the CMO at Virginia Mason Memorial, about what that structure would look like regionally. As Matt knows, when we cross that line, there are expectations for both local and regional triage activities. My sense is that there's very little awareness of that in our region outside of this building.
Thanks, Dr. Martin, for bringing that up, Matt Altman. What are the plans what's the next step to start the local kind of triage committee work?
One of the ethical principles that's going to guide that is supposed to be consistency. And so the committee yesterday met and agreed on some general principles, appreciated your volunteering, and you're on it, I'm on it, the rest of the committee has yet to be staffed. But the thought was that before we started getting into specifics, if this is supposed to be consistent across a 4-hospital territory, that we probably ought to have conversations with the other 3 hospitals so that we're all working from the same playbook.
Yeah, that makes perfect sense. Of course, we don't want to get sort of caught flat-footed or anything, but yeah. So I know we need to move carefully, but swiftly, I guess.
Well, and
thank you.
Talking with Dr. Brugman today, VMM has been looking internally at their processes, but hadn't been thinking regionally at all. As best I can tell, I'm not sure that there is a CMO at either of the Astoria hospitals. I can't identify that online. I was trying to reach out today, and it may be some other representative, perhaps their chief of staff, I don't know.
So one of the things that's really missing from this process is, from my perspective, no one has been able to answer for me when they pull the trigger on the DNCC activation. And from my perspective, given the pressure on the Yakima market, I think it is time. So not necessarily to move to crisis standards of care, but to move to sort of a 4-hospital asset monitoring kind of situation. So again, Dr. Larson has indicated that he'd be willing to participate in that conversation, and I would like to move to having regular updates and understanding how that's going to work sooner rather than later.
Thank you. Anything else, Julie?
That's it for me. Can I ask, outside of the regular structure, hopefully Morgan Anderson is still on the phone?
Yep, I'm still here.
Morgan, can you lead off this conversation talking a little bit about our PPE resources and what you're doing in terms of supplies, equipment, and PPE?
Yeah, of course. So we've always been known as a department that gets scrappy when we need to. So we have been hoarding surgical gowns for a while before all this hit, because we had a recall that happened with our pack supplier. So we've been trying to obtain as many of the PPEs that we possibly can. We've received one order of support from the EOC, but right now there's been some change in how the EOC is obtaining supplies, and so we're not really getting straight answers there. So it's just kind of a waiting game at this point to see when we get our next lot. We have seen a lot of community support. Lots of people have offered to sew gowns and masks. The masks at this point are not intended to take the place of N95 masks or surgical masks, but they're more intended to go over an N95 mask in order to ensure that the N95 mask can be used more than just with one visit, but the cloth mask can be turned into laundry, it can be washed and then put back. So we're trying to come up with creative ideas and ways that we can not have to go through so much of our critical supplies. Sterile processing has started to to create masks as well, sterile masks, using the sterile wrapping that they use for all the instruments. And they were able to produce about 60 masks today. And we're also working on creating face shields for the staff that are doing aerosolizing procedures or coming in contact with known COVID patients. The college, Central Washington, provided us with a bunch of the material needed for the shield itself, and we were able to obtain the rest of the supplies through Amazon and local vendors. We are looking closely daily at our supplies and coming up with creative ordering opportunities. We've reached out to local distilleries in order to obtain hand sanitizer. So both Ellensburg Distillery and Heritage Distillery have been working with us to give us hand sanitizer, which is another item that's very hard to come by right now. Gerald's has also been great. They provided us with about 4 cases today of Clorox bleach wipes and are expecting more tomorrow, so they've been really wonderful as well. We're doing everything we can to make sure that the staff has what they need, but also working very closely with infection control around, the creative ways that we can still make sure that the staff is protected, but also making sure we're not going through the supplies as quickly as we are accustomed to, just because we are in a shortage.
I'll just point out that Virginia Mason Memorial borrowed the design that our central supply staff created, and they're using it for their mask shortage as well.
Thank you, Morgan. Appreciate it.
Thank you.
Yeah, way to be creative. Yeah. Any questions from the board? Anything else, Julie?
Yeah, if we just want to move into operations and with starting with Vicki and.
Yes, needless to say, the last 2 weeks we've been working really diligently on coming up with a surge plan, which I think we pretty much finalized. Of course, if we need to tweak it, we will. In the event of a surge, we've decided that we can have additional beds ready, and that would be doubling up the rooms on med-surg. Currently, they're all private rooms. Back when they were built, they were intended for double rooms, so we would go back to that model. We've come up with creative screens to put in between those beds. Our engineering department has used PVC and sheets to do that, which will be adequate. We've also looked at the oxygen and air, compressed air, and the suction capability in those rooms, because that's what's required, and that's what patients will need, and our engineering has really come up with some creative ideas to make that as well. Then moving on to the CCU, we can double up some of those rooms as well. Not all of them. 4 of those rooms can really accommodate 2 patients. We looked into what the ED would look like if it became inundated, and just last month we had a day where we saw 60 patients, and that was quite challenging. We do surge those patients into the surgical outpatient department, and that process has been working really well. We just need staff to cover that, and Dee Dee's been working really closely in getting additional staff. An APC would follow those patients into the surgical outpatient area. They have computer access, medication access. They do have a cart already made up. So that is intended for short stay patients. Then in the event we get ventilated COVID patients, we looked at all our equipment. Currently we do have the capacity for up to 8 ventilators and possibly 2 more when we look at our anesthesia machines. Those patients would be cohorted into what is now the recovery room and the endoscopy rooms. That's all negative pressure, and it's a confined space, and it's conducive to critical care. So that option seemed really the best option in regards to ventilated patient care.
Did you say up to 10?
Yeah, currently we have portable ventilators, some standalone ventilators. We are looking at how to change the CPAP and BiPAP machines into ventilators. We have 3 anesthesia machines. One would be dedicated to surgery, but the other 2 could be adapted for ventilators as well. And we have put in a request for additional ventilators, but
Additionally,
Vicki, I did have one quick question about that, because I had heard that you could adapt the anesthesia machines to be ventilators. I mean, do they work just as well as regular ventilators, or are there any drawbacks to that?
the intent is for short term up to 6-8 hours. So I do know they are looking into the option of whether or not that could be converted for long-term use. The other is the ventilators currently can be adapted to accommodate 2 patients. They would have to be 2 like patients because you couldn't have different settings on one ventilator. One ventilator would have one set of settings for 2 patients.
and theoretically, you can go to 4.
Yeah.
The limitation is how much tidal volume the machine can deliver, how much air per breath, and you can essentially run it at high enough volume to support 4 people as long as they're well matched. If you have somebody who's much bigger than another patient on the vent, the little person gets more air.
Any other questions about the vents?
No, thanks for clarifying.
The family birthing unit was, we did a walkthrough through there. That is our last resort when it comes to surging patients. The predictability of the census and FBP is, different from day to day. And there really has to be a select patient population that we could place there safely and keep our moms and babes safe as well. The ED did look at surge capacity also, and are planning to have a triage tent area outside of the lobby so that we could fast track patients at triage and put them in the right place. Some patients just need short stay, some patients may just need an x-ray, some patients may just be a look in the ear, so you can get those patients treated and then out back to their homes quickly rather than tying up an ED room. That's why we looked at the surgical outpatient space to do that fast tracking of patients. We also looked at the surgical outpatient space for the use of those mental health patients that end up staying in our ED anywhere from 6 to 24 to 36 hours waiting for disposition. So we could move them out of the ED where those patient rooms are needed for more critical patients. What else did we talk about? Equipment.
So Vicki, currently census is about what it's always been, or is census up?
Currently, we're below our prediction on inpatient census.
Okay.
OB is steady, med-surg and CCU has been down for the last 2 weeks.
Okay.
We did also relocate our wound care and medical outpatients to the old Ellensburg Pediatric Clinic here on campus. So they are doing their services in that building, which frees up more space in the outpatient department in the hospital.
Jessica here, I've got a question. I'm having some phone trouble. If you can't hear me, please let me know. So I know that we've got, I think, six cases, confirmed cases, according to the DOH site in the county. Presumably, though, there's many more cases that have been family testing and just presumed positive. Are we seeing a lot of this traffic in the hospital now of patients who are likely positive but are not confirmed cases?
Not necessarily. Not a lot of them, no.
Well, a lot of them have been tested.
Right, they've been tested and they're at home.
So the number today is 8 that's been confirmed in Kittitas County. And I think that we've had, correct me if I'm wrong, we've had 3 patients that were in beds being tested.
And those were all negative.
Those were all negative.
And those,
Yes.
so we're testing patients on the inpatient side. We've treated 1 known COVID-19 patient. But one of the things that we have done is dramatically restricted access to the hospital. So that is the technique that we're using to try to keep as many of those family members and contacts out as possible. The other thing I would point out is our volumes in the emergency department and urgent care, and Carrie can speak to the clinics, but those volumes are all down dramatically as well with the stay-home order.
Great. Any other questions for Vicki? Thank you, Vicki.
I just wanted to mention, as far as the staffing, we have looked at all of our clinical areas and our, especially the surgical outpatient area where there's a lot of staff that can be redeployed. And so we're looking at what education needs. We've had a lot of volunteers of a lot of nurses and staff that indicate they would like to float and were willing to float in the event of a surge. So we are looking at each department independently and accessing those volunteers and even those who don't about what kind of jobs they could be doing in the event of a surge.
Great, thanks. Rhonda?
Sure. We've worked with Vicki, Ron, Mandy for infection control, and also Dr. Hibbs and Dr. Martin. Actually, a whole team of us went walking through the hospital, really looking at the plan that we had for surge and how to manage patient flow from an infection control standpoint. And because of that, we came up with some recommendations and some modifications that we will be making in the facility itself. Ron plans to put in the emergency department entrance area sort of a little false roof over that so that it doesn't go up to the mezzanine, and that's to help with airflow and infection control. We also looked at how we would move patients who are potentially COVID-19 positive throughout the facility. What's the best way? How can we block off a traffic pattern for that? And then also, how would we move patients who were going to surgery without having them come into contact with a COVID-19 unit? Because of that, we are looking at blocking off part of the hallway in the surgical outpatient PACU area, and then building an exterior structure on the ER department side and the surgery side that would allow us to take patients outside the building and then back into the operating room without having to go near where we would be keeping any COVID-19 ventilated patients. So Ron plans to get started on that work, and he said yesterday he was hoping he could have that completed next week. So that's a change in our little surge plan that we have.
One other wall too would be in the OR itself.
Yes.
So there's one other structure.
Yes,
Yeah.
to block off the area of the nurses' station and the locker room so that the staff would have access to that sort of on the clean side, maintaining the positive pressure that we need for the ORs compared to the negative pressure that we would be needing for the COVID-19 unit, and then just also a separation of staff, kind of clean, dirty area. So that's, any questions about that?
Yeah, Rhonda, what's the threshold for surge? Like, at what point are you defining, hey, we're having
a wonderful tool in their electronic health record that lets them know how long the patients have been waiting, how many they have registered, the length of time that they've been waiting, and their acuity. So it kind of is calculating a figure for them, and they're building that into their trigger for overflow and opening that unit. The other piece, as far as when we would start putting patients back in the recovery room and the endoscopy area, will really depend on how many patients we have admitted and needing ventilator care at any given time. So if we exceed our capacity, maybe at 3 patients back in the CCU, with other people filling up our med-surg area, we would probably go ahead and open that other unit. But I think it's going to really depend on the staffing and the resources and the patient flow at the time.
So can I just, one of the things that really struck me as we thought about caring for these patients is we are used to an average length of stay of 2 to 3 days. These patients are going to stay much longer. That is what they're experiencing in other settings. So when we admit a patient who's sick with COVID-19, we anticipate that that patient's going to be in that bed for 2 weeks, for 3 weeks. Now some obviously who are less acute will come and go, but they come, they claim their space, and we build on that. So if you look at our county and think in the next 3 weeks, you know, we may only have, call it a dozen COVID-19 admissions. That's 12 beds that are full at the end of 2 weeks. So that's one of the, when we talk about surge, it is less, in my mind, about admissions and more about occupancy.
Yes, we always want to have some of those critical care beds open for people who might be having, you know, potential MI, stroke, any other trauma that we may have, or medical condition that needs intensive care here. So we don't want to fill up all of our CCU with COVID-19. And we really do want to try to cohort all those together in the other unit once we get to that point.
Great, thank you. Any other questions from the board? So we'll switch over to Carrie Barr, who just came back from vacation, I understand.
Oh, I came
That's
back
forever ago.
exactly 11 days ago.
11 days ago?
11 days ago.
Like 6
Clearly
months.
under the window.
Well, welcome back.
Yes, I don't know what you all did to the nation when I was gone, but it's broken. So, anyway.
It all fell apart.
Right. So, anyway, so what's been happening in the clinic? So, you know, you all know we popped up a COVID clinic on March 6th, as along with a COVID phone line for patients and community members to call. This clinic is open 7 days a week from 9 a.m. to 5 p.m. Each day we're doing daily adjustments to standard work and workflows. We learn a little something every day and tweak and perfect. So we have even tested out a process for parking lot testing if we felt like we needed to do that. We have done that in a couple of scenarios. At one point we thought we were going to be doing some testing or sort of surge testing, but since then that is also adjusted, but we're ready if needed. So we're missing 3 days of this data, but so far 427 patients have gone to the clinic and have been seen, and 242 tests have been sent from the clinic, 335 sent from all departments. Any questions about the clinic, the COVID clinic or the flu clinic?
Well, I mean, I think it's a great thing that set, and it was an amazing idea to set up the clinic. As far as in the clinics themselves, they're taking emergent patients,
Yeah.
and how is that working? Are you just having provider and MA and everyone else is at home, or what's going on there.
So you mean in the other clinics?
Yeah.
Okay, so, yes, so we have lots going on in the additional clinics. We're working on workflows, again, every day to just daily adjustment to keep our patients and our staff safe. We bring in well patients in different doors when available, but trying to keep well patients and sick patients. The reason we're still bringing in some well patients is because we want to make sure we continue to vaccinate kiddos and not have a measles outbreak amidst all of everything that we're doing. We are creating social distancing, so we have adapted our waiting rooms to account for that, and we have taped off spots on the floor for patients to stand so that it's so far away from to interacting with the front desk. But we have also initiated calling the patients the night before, and this is just as a recent, we'll call them the night before, we'll update their demographic information the night before prior to them coming in. When they arrive at the clinic, they'll call from the parking lot, at which point we have them, then we can tell them, we can call them and tell them when it's time to come in for their appointment, so then they go directly back into the room and they're not sitting around a waiting room. We are conducting vaccinations now in the parking lot, and we are also conducting INR pokes for our Coumadin patients in the parking lot. So we've got a lot of staff hanging out in the parking lot these days. So let's see. Some of the other things that we're doing. Yes.
Eric, I just want to say kudos for the flexibility and the nimbleness to adapt to this and do parking lot medicine. I think it's incredible. It's unorthodox for sure, but I think that it's definitely needed for best outcomes. So good on all the staff for making that happen. That's great.
Yeah, I'll pass that on. Thank you. I really appreciate it. They have been incredibly flexible and creative, and I think we're finding probably some of the best practice of how to give a child a vaccination could be while they're strapped into a car seat. So, anyway, some other things that we're doing, we are setting up Bob, to your point, we are setting up criteria of what type of visits we should be seeing and how those visits should be seen. So what makes sense for telehealth, what makes sense via telephone, what makes sense that we can do in the parking lot versus what actually has to come in the office. So we're getting that criteria set up. We are down in visits, anywhere to 100 to 150 visits daily that we're down. So that's we've got luckily some time to be nimble and creative, and to learn about telehealth as well. We are putting together a list of inventory of clinic facilities. So just what are some of the other things that the hospital may need from us, things like oxygen tanks, nebulizers, wheelchairs, and we just finished that. There's just always, we even had an IV pole hidden in one of the clinics. So you just never know what's in, you know. Yeah, Morgan's team isn't scrappy, clinics are scrappy. So yeah, we had some hidden gems that we now have a list of that we can pull those resources if needed. And then the last thing I wanted to mention is we're putting together just a provider assessment. To Dr. Martin's point and to Julie's point, these people, we've got some really, really talented folks on our bench. And they're all, the volunteerism that we've got that is already happening it's awe-inspiring, and you would all be incredibly proud. And so we wanted to get that down on paper in terms, so when we're in that maybe a panic surge mode, we know we've got this documented, and HR will have it, Dr. Martin and the admin team will have it, that we can say, hey, we need some additional help in general surgery. Well, guess what? We have a PA who has actually some background in that area, and we can pull from that. So So that's what we've just finalized that today. There's still some additional tweaking that needs to happen with that, but anyway, so that's what we've been up to in the clinics. Any questions?
So one of the things Carrie did right out of the gate was create a to-do list for her staff. As the patient volume reduced, we want to keep this staff engaged. So this is going to be critical staff for if we hit a surge point for runners, to help with materials management, to help in many, many places in the organization. So, part of the commitment the board made to the employees to keep them whole to their FTE included cross-training and, learning to function in other places in the organization. But even before they got to that, Carrie created this list. I think everyone in her clinics, there's not a delinquent chart in the organization now. Everyone is done with all of their continuous education and everything that they needed to do. So this is a really valuable resource in terms of skills and knowledge about the organization that we want to keep engaged. And the same is true with Vicky's folks back in surgical outpatient and medical outpatient. So tons of cross-training going on and just really poised to be ready.
I did have one quick question about that. This is Matt. Regarding the cross-training, I know that sometimes during non-emergency times, there's a little resistance to a lot of cross-training, but am I right in assuming that people are up for it this time around?
From the nursing perspective, yes. From the list of staff, I asked each department to list their current skills and ability and what they would be willing to learn. And the willing to learn was kind of awe-inspiring, as Carrie used the word. I was surprised at some of the names that came up that said, yeah, I would like to work on med-surg. I would like to work in CCU. So for the most part, I think they realize that this is really what's needed for this time, and we're kind of all in this together. And the fact that their volumes are down and they want to work.
Yeah, it's something that came up during the AHA conference call today on the coronavirus was at some places some providers are maybe trying, who maybe don't want to have to deal with this, I don't know, but are trying to take advantage of family medical leave, to take care of their kids, or with lower, elective surgeries and things are asking to be furloughed. You're not seeing any patterns about that, about people who are trying to kind of take off for a bit.
Can I hand that off to Amanda Scott to answer? They're actually methodically handling all leave requests and have done an amazing job of talk about learning on the fly, because a number of those leaves are brand new to us. So Amanda, if you're there, can you?
Yeah, definitely. So we actually have seen quite a bit of an increase in our requests for leaves and accommodations. A lot of that sometimes is a fear of whether they're feeling ill or not, but fear of perhaps bringing something home to a loved one or to themselves, or what we learned through this is just everyone has a different situation, a different comfort level, a different just level of health needs and concerns that they may have for themselves and their families. So we're really trying to help coach them through that. I have to give a big shout out to Workplace Health and Infection Control. We've been really partnering closely through that so that we can separate the employment and medical information for good reason, just to respect privacy, but also send our employees to resources through Workplace Health and Ryan R, so that they can get some consultation and really identify what is a low risk versus a high risk in their situation. And I will say that Ryan has kept a lot of people working because of that, because he's been able to help them understand realistic risks and actually identify the facts. We do have about 30 people, kind of cases that we're managing of people requesting leaves or accommodation for various reasons. We usually only have about 40 per year, and so it definitely is high for us. But of course, with everything going on in the media and public health and trying to match their guidance with kind of their own realistic circumstances for their health, we're trying to find a balance of supporting them and helping them, but also understanding that we are essential workforce, and there are roles that their primary essential job function is clinical care, and we need those people. So we're really working with the managers on that to determine what are their operational needs and how can we help them meet those and try to help the employees where it makes sense at the same time if they are needing a leave. So no real change in our policies, just a lot more volume. We have a leave request form that everybody fills out, and we have an accommodation request form. The accommodation request form typically is a work from home. That has been the biggest area that they've sought accommodation for right now. And again, for some people that makes sense and that matches their job duties, and it's up to the manager kind of operationally of what works for them. But for others, frontline staff, that's of course a little harder to do. So if there is projects or work to do that matches, then that may work. But other times we may need them on the floor with us right now. But for the most part, we've had a lot of volunteers saying, how can we help? A lot of our administrative staff who normally don't see patients at all have stepped up, and we've tried to help staff and coordinate the visitor check-in process and tried to help send people over to help with phone calls at the flu clinic. And there's a lot of people that are really wanting to help right now. So and there's also a lot of regulatory changes, as you mentioned, with federal law and state law, more expanded benefits through the state. And so we're trying to really just help employees get connected to those services. At this point, we have not had to actually make change to our leave and benefits policies. We're really just trying to help them get connected and adjust our allowances based on the laws that are evolving constantly.
Okay, yeah, that really helps me understand. Thanks.
Yeah, you're welcome.
Do you see that potentially changing? I mean, and I have no idea how true it is, but how folks being on unemployment can actually make more money in unemployment than actually working, and mainly for hourly wages.
I was on an AHA call today, and a number of hospitals raised that issue, and I just, there's so many moving parts in that COVID 3.0 that's moving back in DC. I'm not sure anyone knows how all these are going to fit together. So
yeah. I do think though that the people that have concerns, and I'm hoping at least that the people who have concerns and fears are addressing those now, and that we're hopefully being able to track that well with new processes to track sick calls and things like that as well, and that we're hoping to catch those people early and try to work with them through the process.
Thank you.
You're welcome.
Let's see, Michelle, are you here?
I am here.
All right, community relations.
Community relations. Well, we are basically, my team is working remotely as much as possible at this point in time. However, thanks to Jeff and his technology, we're staying in contact through Zoom and things like that. Our role here is really to support what's happening within the organization, to try and keep both our employees, you guys, and the public informed and engaged. I'm also working closely with the Unified Command of the county. They've been great players in this with us. They have been extremely helpful. As Julie likes to say, there is no sunlight between us and public health, and then they are just being a great asset to us. So one of the things we're going to try and do, we've been doing a lot of written communication. Tomorrow we're going to try and do some one-on-one Zoom employee forum with the staff so they can hear directly from Dr. Martin, Julie, Mandy. Most of us from IT will be there. So we're trying to see how that works with technology to try and answer any questions or concerns they may have. And that's kind of what we're trying to do on this side.
Great, thank you.
Sure. I just want to reiterate again how much I appreciate your messaging campaign. It's clear, it's easy to understand, it's consistent, and it builds on what you told us in the past. And I appreciate how frequently you communicate, so thank you for all that.
Of course, we're open to any suggestions, so please let us know.
So Bob,
Yeah, I love the information.
Bob, if I may, Dr. Martin and Michelle have 7 o'clock conference call on crisis standards of care and communication, and Rhonda and Mandy. Okay. So if you guys can jump in and share your planning.
Well,
Yeah, they can totally go.
mine's been pretty much covered between Carrie's addressing medical staff. We've talked about the preparations for crisis standard care and regional planning, and looking at the DMCC structure. I think you've heard just about everything that, all the pies that I've had my fingers in.
I would, from infection control too, and just in case folks aren't aware, infection control actually lives under quality at KVH, so that's where I'm in this. But it has been really well covered in all the other settings. You've heard about infection control, whether you realize it or not, in what we're doing. So the goals are really to limit the spread of this infection into our facilities. So we've done that by canceling or postponing surgeries, limiting visitors to the facility, having alternative care options like telehealth. The second way is by containing infectious patients that we know about. So this is a standard of hospital practice as is. We routinely have to isolate people who are infectious with other diseases. And that's even true in some cases in the clinics. So they routinely in pediatrics say, gosh, if we've got a sick little kiddo, we're gonna keep chickenpox, keep them separate from our well kiddos. So we're doing that here, and you've heard about some of those changes we're making, taking into consideration the surge capacity. So where do we need to continue to do those options in containing infectious patients, whether that's cohorting them into certain areas, putting up physical barriers, whatever that might be. And lastly, protecting our healthcare personnel from infection. And that goes along with all the engineering and administrative controls we have in place, but that optimization of personal protective equipment. So we've gone to some standards of extended use of N95s or respirators. All of this is along with the CDC guidelines as well as the crisis standards of care for what you do in these situations. Protecting these items with the cloth masks, monitoring their use, providing just-in-time education on different shifts about how you use the PPE, reassuring staff on in these different new situations on how we're using them. And PPE really is, as far as infection control, considered like the least effective and the last resort. That's why we put all these other strategies in place, but we're still focusing on that. I think the COVID clinic is a really great example of all these techniques. We are making sure that people we know and have identified as potentially having this, they're already isolated to their own area. There's dedicated staff there that are putting on PPE to begin with and putting on source control, so masks for the patient there. And it really has been successful. The majority of our positive patients have been identified out of that clinic. So our staff are wearing appropriate PPE, the patient's wearing what they need to wear, they're separated from other parts of our facility. It's really been a great example of all these techniques. So and just to reiterate too what Amanda said, an important part of this is in protecting our healthcare personnel is assessing when we do think we have potential exposures, and Ryan has just been really great. Not only is this is his job and he's good at doing it, but he has a phenomenal communication style and really is reassuring to our staff. So we really appreciate having that service as part of our organization. And that's all I had, unless there's questions.
Great. Thank you. Any other questions from the board? As terrible as this is, I mean, this has potential of really being a tipping point to, you know, truly change healthcare and truly change our use of technology.
It really does.
Who knows where this is going to go, but hopefully we can get some resolution. Really, really proud of what the hospital's done. And it all starts with the senior leadership and with the CEO, so thank you all very much.
Well, can I just say, you know, one of the things that we've said from the outset is that we're not in the business of predicting. We're in the business of planning, and if nothing else happens, we are going to come out the end of this knowing where our gaps are and knowing what our strengths are. And that pertains to everything from facility controls to equipment, access to PPE, but also in the relationships and the way decisions are made and the way we balance and respect and treat one another as experts in our fields. And I just have to tell you, the experience with Incident Command has just been outstanding, and I can't tell you how much respect I have for the people who are contributing to this planning. So we're going to come out the end of this knowing a lot more about ourselves as an organization. So I think we'll be out of cash, but we'll be a much stronger organization. So.
Yeah. Okay, so I don't really see any need to talk about education or board reports unless the board has anything, or any old business or new business.
Under old business, Bob, did you want to leave the April board meeting on a special date or move it back to the 23rd?
Let's move it back.
Okay.
I would propose we move it back, but whatever the board wants to do. What are your thoughts?
I'm flexible.
This is John. I'd like to move it back to the original date.
This is Terry. The original date was fine with me too.
Yeah, either way is good. Doesn't matter.
So we will reschedule it sounds like, for April 23rd.
Thank you.
Sounds good.
So at this time, we will close and.
I'm sorry. I did have one quick question. Have we talked about our April 3rd retreat? Are we gonna? Are we gonna do that electronically, or are we canceling it?
I apologize. We canceled that and are planning to reschedule. And I believe at this time Chelan is also a probable cancellation. So we were going to regroup. Just the logistics of trying to do that while social distancing and staying at home was getting really difficult. So I apologize. I should have said that much earlier.
Okay. Yeah. Thanks. No, that's all right. You may have mentioned that. I just missed it.
So yeah, thank you, Matt. At this time, we'll close. We'll take a 5-minute break to move into executive session.
And I will be asking for action at the end of executive session.
Okay, great. Thanks, everybody.
Thank you.
Appreciate it.
Thank you. See you in 5 minutes.
Yes. My mom's watching. Your mom's watching. Hi, Mary's mom. Hi, Mary's mom. Good night, everyone. She was like, your dad has a CPAP. Can we? Oh. I'm like, Mom, I don't think so.